No, because people cannot open from outside.
All right, so today we're gonna finish with the third lecture about the home and IV. So I told you on the first lecture about, starting home and IV for COPD. The second lecture was about neuromuscular weakness, thoracic restrictive disease, and obesity hypoventilation syndrome, the rationale of why we advocate for it and when and how we can get it, started. And how we can get it prescribed actually through the CMS. But this lecture is going to be guiding you on how to write the prescription. And believe me, guys, it's more than BiPAP minimum and BiPAP, or what they call like pressure support maximum. Our understanding, this is what I noticed even at our own level, higher level, is very superficial about AVAPs when it comes to writing prescription. And as a pulmonologist, we should tailor the prescription toward the pathology being treated. Okay. So, all right. So I have nothing to disclose today, even though I'll be talking about, Respironics and ResMed devices. So the presentation will be to help you to write the prescription for home and IV. And as I told you, it's not just a superficial, thing that we're going to be talking today. So it's in depth, and I think every one of us should know this. Because we have to tailor the prescription for home and IV to the patient's respiratory mechanics and the pathology being treated. And hopefully I will get some few slides, because it's very important is not just only how to prescribe it and what to do for these patients when they come to follow up with us in clinic. And I want you also to think about it as a mechanical ventilator that you start patient in the ICU, because we don't start people on it and we just walk away. So we go and do serial APGs, stuff, and every day sometimes we have to change it every day to make sure that the patient is thinking well and the ventilator settings are safe, protective, and effective. So we're going to do the same thing with some variations when we see them in clinic as well, to make sure that the prescription that we wrote them is working for them. So with this, I think you need to request these slides and keep them, handy when you write the prescriptions. I'm not going to go through the details, but they have everything you need. And the nomenclature that you have here, this is what you might come through if you are prescribing stuff or you get letter from CMS denying or approving. So like the devices, so they, abbreviate them in this way if you want to take a look at it later. I'm sure that you've heard about the respiratory assist device and this term. So initially, it was only like a terminology that was used by CMS and national payers in this country. But lately, it started to kind of invade into the medical literature. But what they meant is just simple NIV like CPAP or BiPAP, including even spontaneous BiPAP. So we have the mechanical ventilators that we know in the ICU, and the hybrid mode or the hybrid mechanical ventilators. So they can be used, in the hospital or at home, and they can be used both in invasive and non-invasive interfaces. And I will be talking today about this category, specifically the Trilogy or the Respironics devices. So VAPS. So this actually acronym stands for Volume Assured Pressure Support. So it's some sort of pressure support, but the volume or target volume will be guaranteed over a minute, and I'll show you how. So it is something that is very convenient. We can start in and outpatient settings. By the way, VAPS with the new, especially like the hybrid modes, it's an add-on software, so you can have it. So it's not like a ventilator per se, it's some sort of, a pressure support. And it's meant to augment someone's spontaneous breathing, because if you have someone who's apneic or not breathing well, even in the hospital, it's not the time to put them on AVAPs. This is if you have someone who's breathing their own and you want to help them. So it doesn't replace the need for a mechanical ventilation when needed. And I'm not in this presentation going to persuade you that the VAPS is better than BiPAP ST in any means, but the reason that I chose, guys, to educate you about this, because we use it a lot, and most of our patients that we see in clinics, they are on Trilogy, whatever. I'll explain it to you, and VAPS, and we use it in the inpatient setting. And I want you to know every single details about VAPS. So you should be mastering this very well. But about the diseases and the pathology that I talked to you about in the first and second lecture, VABS is equal to BiPAP-ST from the data that we have, so it's not better. But I chose to speak about it because of the ease and how it's prevalent in our community. So VABS and AVABS, compared to BiPAP-ST. BiPAP-ST is that means a spontaneous time. So both of these modes, they can guarantee some kind of minute ventilation because they have a backup rate. Okay, but if you concentrate in your left side, you'll see the BiPAP-ST where the IBAP and and the pressure support is fixed. Okay, the first two breaths. So IBAP is fixed and EBAP is fixed. And therefore, the target volume might vary depending on the lung compliance. So if the lung compliance goes down, so your tidal volume will go down as well. So the advantage that the AVAPs actually has, which BiPAP-ST doesn't, which is, even if there's some change in your lung mechanics or there's a mask leak, so the machine can adjust. If you see the pressure, it's ramping up. So over a course of several minutes, it can achieve the target tidal volume. Okay, so but in clinical trials, as I told you before, that hasn't actually translated into a significant, meaningful difference thus far. So, for example, like if you see at the level of the patient, like if I'm giving this patient a breath and there is a significant leak, maybe I dial in 500 in the machine, but the patient doesn't see it all because part of it will be, escaping from the the unintentional leak from the mask. Maybe the patient sees 350. So this machine over a course of, several, breaths, so it will adjust the pressure by increasing it in order to account for the leak. So eventually the patient will get the desired, tidal volume. And by the way, when I say full volume or volume assured pressure support, that doesn't mean that every breath is going to be whatever you said, but over a course of a minute, it can adjust it and your minute ventilation will roughly, stay stable, but it's not breath by breath. So this is just to remind you and refresh your memory about the pressure time curve for any, pressure supported ventilation. So you have EBAP, CBAP, or EBAP. They are all, for the sake of this discussion, synonymous. And you have the trigger either by the machine or by the patient. And then you have the rise time, which is the time that it takes the, the pressure to increase from the EBAP to the IBAP. They call that the pressurization time, and then you have the inspiration time, the time during which the IBAP is maintained for, and then you have the cycle, which can be time according to respiratory time or depending on the patient's flow if the breath is spontaneous, and I'll explain that to you. So AVAPS is no in any means exception from what you know from pressure supported ventilation. So today I will be talking about this device, which is the Trilogy. It's made by the Philips Respironics company, and also I'll be telling you about the ResMed because in the US those are by far as the vast majority of the devices that you will be encountering is Philips and ResMed. So I'll be telling you about both when it comes to this VABS. Mode of ventilation, because this software is available in these two devices. So as you see, on the left side column, so I have ResMed, and then on the other side is Respironics. So there is, I'm not sure if you guys heard about IVAPs before, because IVAPs and we have AVAPs. Okay, I don't want you to get kind of lost in this. So the Philips Respironics is the AVAPS, which is average volume assured pressure support. Okay, the other one is intelligent volume assured pressure support. So roughly they are about the same when it comes to their efficacy and how and the effect that you're going to achieve, but there's a little differences. So the difference, so the one that you're using here, either in the inpatient or in the outpatient settings, is the Philips Respironics Trilogy, which is the AVAPS. Okay. So you will, choose your target, which is the expiratory tidal volume. So you set it up for the patient, which is roughly for most of the problems or the sleep-related hypoventilation disorders like COPD, muscle weakness, chest wall deformity or sleep or obesity hypoventilation is going to be 8 ml per kg ideal body weight. Okay. But on the other side, for the intelligent, there's few differences. But one of the major differences is that we choose the alveolar ventilation to be the target. So it's not like the exhaled tidal volume. Okay. So, and as you know, the alveolar ventilation is your minute ventilation minus your, dead space ventilation, right? So this machine will determine, so the default, if you are going to start this ever on anybody, so the default minute ventilation will be alveolar ventilation will be 5.2 liter per minute. And the machine will calculate this based on the patient's height, because it will take into the consideration the anatomical dead space and also the machine set backup rate. Okay. But this is one of the major differences, and there are some other differences that I'm going to tell you about as we go through. So, do you have any questions? Are you with me?
Yeah.
Okay. So we're not using the IVAPs, but just I put it here for you, to know about.
Dr. Mohammed sent a message.
Sorry.
You only see the slides.
If you are muted.
No,
No.
the mic is open.
Can you hear me, Dr. Man? No, I'm not.
Share, we didn't share it.
I think I let her do it, Caitlin. I didn't do anything.
I can hear you. It's just the first. I only see the first slide where it says home NIV initiation.
Maybe she have to.
So the slides aren't advancing. I don't know if there's something I should do or not. Ah, okay. I can see them over at the side now. Now they don't come up.
What's about now?
Oh, okay. Now I can. What slide are you on?
I will.
I know the number, but
Okay.
So do you see the slides moving now? Are
Yeah,
you with us in the VAPS prescription?
Yep, I got it now. Thank you.
All right.
okay. All right. So this is the first thing that we will use when we write the prescription. Okay. So I've heard some last year, some of my fellows kind of challenged me. I mean, I think we have, when we write the prescription, write the IBAB maximum and the IBAB minimum. So what is actually even the company, brochures is the pressure support maximum and pressure support minimum. So first of all, number one that we need to set is the maximum pressure. Okay. So if you see like across the board, it's almost 30, 25. Okay. Because we don't want the pressure to go that high, because theoretically you can cause, lung injury like pneumothorax if someone has like bad emphysema. But there is no data actually that, supports all of this. But with taking the patient safety into consideration, so we always tend to make it like not more than 30 to 35 at maximum. Okay, so what that means, this is not the machine is set to not let the IBAB go beyond this. Okay, so you have to keep in mind so that this is a pressure that you dial on the machine, but the IBAB and your machine will not let the IBAB go beyond this. Okay. So what you need to write in your prescription is your pressure support maximum and your pressure support minimum. And the pressure support, as you know, is the difference between the, EBAB and the IBAB. Okay. And it's different across, these or this disease spectrum, with the overlap of sleep apnea and COPD and obesity hypoventilation is the one that would require, more pressure support. And the reason that I'm highlighting that in green, because on the data that I told you about the COPD, so the average high intensity, and I told you about the high intensity pressure support, and this is the only pressure or NIV, home NIV, that was shown to decrease mortality. And the average pressure support on that is 15 and the clinical trials that were done in Europe. So it's a very, high pressure support. So you start usually between, I should say, 5 to 20 or 25 if you're having obesity hypoventilation or the overlap. And then we have the EBAB. So the EBAB, so there is minimum and maximum as well. Okay, and you have to know that if I'm using different set of EBAB, okay, the mode in this situation is going to be called AVAPS-AE, which is, auto or adjustable, EBAP. Okay. So if I'm using this, but if I'm using fixed EBAP, then the mode is going to be VAPS. And this has a clinical application because VAPS AE in the United States, it's only available in home ventilators. Okay. But in Europe and, other places, so they have it. It's just an add-on software. You don't have to have a home mechanical ventilator in order to be able to deploy or to apply this kind of mode. Okay. But if you have a sleep apnea patient for which their CBAP, optimum CBAP, you don't have to use this variable pressure. You can just only choose your CBAP. And the only trick is that if you have obesity hypoventilation and it tells you that their optimum CBAP is 2 and they are failing the CBAP for whatever reason and you want to switch to AVAPS, then the optimum the optimum EBAP is going to be their CBAP from the PSG plus 2 centimeter water. Like if in the study they required, let's say 13, then you put them on 15, okay? But if you don't know their sleep apnea status, they have not been tested, or you have a clinical suspicion about it, but you have not tested the patient, you can use the variable EBAP. And it's recommended to do it in this range 5 to 15 because the machine is not going to jump to 15. It will only give the patient whatever it takes to open up their airway and take care of the apneic event. Okay, but again, so when you write the prescription, it's not the IBAP minimum or IBAP maximum. It is the pressure support. And then it's up to the machine to decide how much pressure support it needs to apply in order to achieve the target, which is the tidal volume in case of Philips Respironics. So this is, I'm just jumping ahead of myself, is just what I told you about here. So then the backup rate that you need to write in your prescription. So there's 2 ways in ResMed and the Respironics trilogy. So either you set up the respiratory rate yourself, okay, or let the machine auto set it. Okay, if you don't choose anything, it will just go to the default, and the default is the machine will sense the patient's breathing pattern at night, and it will give the patient some kind of a backup rate, which is usually analyzing the last 10 breaths and determining the respiratory rate based on that if the patient goes apneic at night. And then don't get that confused with the VAPS rate. So backup rate is the one that which is the factor that we need to, when you multiply it by your tidal volume, it gives you your minute ventilation. So the VAPS rate is the rate or the amount of pressure that the machine is allowed to increase per minute in order to achieve the tidal volume. Because when you start using or applying the AVAPS machine, especially like in the acute setting, this is important that the machine, don't think that the machine will switch from like a pressure support of 5 to 15 in few seconds. It will take time for it to get there, and that depends on what you dial it in the machine in your settings. The default is 2 centimeter water per minute. If you're this minute your tidal volume is 200 and you're dialing it 400, next minute instead of pressure support of like that the machine started with, let's say 10, the next will be 12 and then 14 and so forth. Okay, so if you have someone who's critically ill and unstable, as I said, so AVAPS is not the option here. One of the reasons is that it may take the machine a while in order to come up with the pressure support that will work for the patient. But for home settings, the patients are stable, so it's not like a big deal. So, and then when you write your prescription is the trigger. Okay, so the trigger here, as you see here in this diagram, so the first breath is timed. Why? Because what happened? Okay, so the first breath is triggered because as timed. The second one is triggered because the patient, there's a negative deflection, is trying to take a breath. Okay, so the pressure goes down, the patient start taking a breath. So this is what I mean by the trigger. I want you to pay attention to this because this is different. If you see like on the table on the right, I don't want you to memorize all of this. This is why I told you there's a lot of information here. You need to keep this handy when you write your prescription. So for patients when they have thoracic restrictive disease or neuromuscular weakness, we don't want them to, we want to keep the threshold to trigger a breath easy for them. So they shouldn't be, struggling to breathe. So even dropping their, pressure by a bit, then that will, trigger a breath. So for that, we have either to use what we call auto track sensitive. It's some sort of mode that they call it that way. So you have to memorize this name, auto track sensitive. If you are prescribing this to someone with, thoracic restrictive disease or neuromuscular weakness, or if you are using, this is for Trilogy, by the way. This is if you're using for Philips Respironics, I mean Trilogy here, okay, the machine that we commonly prescribe for our patients. If you are manually setting that, because manually you tell them in the prescription, set it at a flow of, let's say, 1 liter per minute. So if the patient triggers a breath and take a negative, they generate negative inspiratory pressure. So that once they start having a flow of 1 or more, then that will trigger a breath. Okay. If you see COPD, there we're just making it harder a little bit for them to trigger a breath, because we don't want them to have a breath stacking and hyperinflation at night and increase intrinsic PEEP, and that increase your dead space ventilation, and it worsen the ventilation instead of making it easier for them. So a trigger here is important, especially if you are prescribing that to a neuromuscular or COPD. So you have, if you see, the table is completely different between these two categories. And then it comes to the rise time, because it is something that always you write in your prescription as well. So for the most important thing here is for COPD, because for COPD, the rise time is time that it takes the EBAB to reach the IBAB. Okay, so if we make the rise time shorter, so that means you are making your entire inspiratory time shorter and giving more time for the expiration. So definitely for COPDers, people with emphysema and whom you're prescribing, NIV, you need to keep that time in the minimum, because you need to, deliver the breath in the shortest time possible to give them more time for exhalation.
Even in the acute setting in the hospital, yeah, it's better to do it.
Correct. Yeah, I'm just emphasizing this is the same concept that applies there as well. And again, there is no way that from this lecture that you will memorize all these, so you need to keep it handy, but this is the concept here. And then the inspiratory time. So inspiratory time, we have, so it's different across the disease states as what you see here. So if we're, having COPD, definitely will make the TI time shorter, okay? If we are having, someone with obesity, hypoventilation, or muscle weakness, then we tend to make the, the breathing or the inspiratory time longer. So why we make the, for COPD, I just explained it for you, but for the obesity, hypoventilation, neuromuscular weakness, because we need more time for inspiration, more time for gas exchange. Okay, so what keep this, I will show you at the end of this presentation how this is applicable and how we can adjust it when we review the download, the TI/T total. So this tells you the percentage or how much the inspiratory time constitutes to the in comparison to the entire respiratory cycle. Okay, so like with COPD, we want that number to be around 25. So the I/E ratio will be 1 to 3. But in the obesity and the muscle weakness, sometimes we may even let it go to up to like a ratio of 1 to 1, because we want to augment the ventilation. These people, they don't have a trouble with expiration. So what you can adjust here, so the I/E time and the TI/T total, they are variables. So they depend on your respiratory rate, and they depend, your respiratory mechanics, your respiratory rate. But the only thing that you can control here, it's not the I/E ratio, is not directly, is by controlling your, or choosing your inspiratory time in this situation. So the inspiratory time in Philips Respironics, the default, if you don't choose anything, so they will, make the inspiratory time 1.5 seconds. The only difference between, and again, I told you there are differences between the IVABs and the ResMed and the AVABs. It's not just only the one goes with, a target of alveolar ventilation, the other one is target volume. Here, the inspiratory time in Philips Respironics, if you're having someone on AVAPS in spontaneous timed mode, then the TI time is going to be applicable only to the timed breath, not the spontaneous breath. So the spontaneous breath that the patient is initiating, they can terminate them based on their flow. But this is an AVAPS, spontaneous time. But if the patient goes apneic or they become pradipnic, then the machine will, and the backup rate will kick in. Then that breath will get the entire TI time that you are dialing here. Okay, so this is another difference. So this diagram also shows you is just refreshing your memory so that you all know about the BiPAP because it's patient triggered. There is no backup rate and BiPAP, spontaneous, and the patient can control when to switch from inspiration to expiration. So it's based on the patient's flow and it's completely patient related, and the patient has a control on when to switch from inspiration to expiration based on the flow. But when you have AVAPS and the spontaneous timed, it may get you confused this part, but I want you just to concentrate on the diagram in the middle. AVAPS ST mode. So that means AVAPS and the spontaneous time. There's part of the breaths that the patient is taking control of, and if they become pradipnic, and then the backup rate will kick in. So those breaths are controlled by the machine. This is what it means, spontaneous time. So if you see the first breath, the patient, controls the cycling here and they can switch based on their flow. The other one, it will stay for the inspiratory time that you dialed in, okay? The one that I told you in the previous slide. But and in some, I think versions of the trilogy, I can't really remember if it's the V60 or the 100, that also there is another add-on feature to the AVAPS to make it work like a ventilator, okay, like the one that the assisted pressure control, where every breath, whether it's patient initiated or machine delivered, they will actually have the same T time. But we don't prescribe that to our patients, especially like in the home settings. But it is an add-on feature, if you want to know about it. And again, and I'll conclude for this, the TI time is that the one that I told you that you can set it to 1.5, the default, or higher or less if you want. This only if you choose the backup rate, because if you let the machine choose the backup rate, your TI time is not something that you can control. So if you chose the backup rate to be auto set by the machine, you don't have any control about the TI time. It's the machine's job to control. So only if you did things manually. And I think if we're dealing with disease processes, it's better to know what we are prescribing it for and tailoring the prescription to the patient's needs and disease process and respiratory mechanics. Do you have any questions? Okay. One of the other subtle differences between the IVAPS and the AVAPS, okay, IVAPS is ResMed. We don't use it. In addition to the alveolar, ventilation as opposed to the target volume, and the one that I told you earlier, every breath is, the TI time is applicable to every breath, not just only the spontaneous breath. They have here some TI minimum and TI maximum. I feel like this kind of mode is kind of more complicated, but what they want here is that every breath has to end between the TI minimum and the TI maximum. And the rationale behind this, they want to avoid rapid shallow breathing. Like even if the patient wants to cycle earlier, they don't want to rapid shallow breathing and breath stacking and all the negative consequences of that, is to have the breath to last for a certain period of time, which is between, they won't let it go beyond the TI max and they won't let it in shorter than the TI minimum. And this is actually another difference between the two modes. So cycle here is what actually decides when to switch. This is what it means to the word cycle, to switch from inspiration to expiration. So it is important in the case of COPD is to make sure that we don't we increase the expiration and make the inspiration the shortest possible, and provided that it provides the patient with some kind of ventilation. So in COPD, you either use what we call sensitive auto track, Remember, we use the sensitive auto track mode for cycling. We use it for trigger for muscle weakness because we want to choose the most sensitive. Here for COPD, when it comes to the cycling, COPD patients, they need to get the most sensitive, cycle, parameters here because we want them to finish the inspiration as early as we can, okay? Or either to let the machine do it when it's sensitive auto track. You write that specifically because the DMA respiratory therapist supposedly going to be set your machine using what I have for you here in the table. Or manually, you tell them, let us cycle at 30 or let's say 40% from the peak, flow rate. And this is the same feature that you see even with mechanical ventilators with, BiPAP, whatever you're using in the ICU. Let's say the patient started with a peak flow of like 100, for example, liter per minute. So when it decreases to its 40% of that, okay? So then this is actually a sign for the machine to switch from inspiration to expiration. Any questions? And ResMed, you read this table because I know that it can get overwhelming, but believe me, these tables, they have everything you need. And also you have to tell tell the the DME company what kind of circuit that you want them to connect the patient to. If you don't choose anything, they will put them on this passive circuit, which is just a single lumen like what you're using for CPAP or BiPAP. Here, rebreathing the CO2 is not going to happen because the mask, there's intentional leak in them. So, or I'm going to show you here. So each mask that we're using for the patient in non-invasive settings, it has intentional leak, which is built in the mask itself, or an unintentional leak. The unintentional leak is the seeping, the mask, the air that seeps around the mask. It is something that we don't need, okay? But when it comes to the intentional leak, it is designed. Otherwise, we'll be rebreathing our CO2, right? Because it's not like a double lumen system and it doesn't work that way. So if you don't tell them anything, they will use the passive circuit, and the passive circuit is good for all the disease processes that I told you about. And it can be even the single lumen used with a trach. And you can ask me how come there is no leak from the trach? But there's a connector here in the middle, so they can connect the trach to the expiratory port. This will work as expiratory valve, okay? So you don't have to use multiple tubing, just only one tube can do the job, and we call this passive circuit. So when you write the prescription, you tell them this as well. You can wonder if it is not like a closed system and there is intentional leak. So how the machine calculate the expiratory tidal volume? So by the way, the machine does not, there isn't any direct way that the machine, measures your expiratory tidal volume to which you are gearing all your, pressure support intervention. It is calculated by some kind of proprietary algorithm built in the, machine itself, okay? Taking into consideration everything, including the unintentional leak. So, and then this brings us to the question, what is considered to be normal leak to begin with, okay? Because you see patients, when you see them in clinic for sleep apnea, sometimes one of the things that you need to do in order to fix the problem when they come to you, I mean, the treatment didn't help me, okay? And then you have to decide what is considered to be a normal or abnormal amount of leak, okay? So I don't want you to forget this, picture here. There is intentional that we want the patient to have, and there is unintentional, okay? This is what we need to make sure that it stays at the minimum. So the answer for this, it depends on the device, on the mask type and the device manufacturer, okay? So when you get the download data, let's say that we're using a Philips Respironic, whether, and whatever is applicable for CPAP, BiPAP is applicable for the AVAPs and Trilogy as well. So if you're using, a full face mask that covers your nose and mouth, and you're using a Respironics machine, so that the sheet that you get with the Respironics, it tells you the total leak, okay? While ResMed, it tells you about unintentional leak. So there is a significant difference in the way that the machine, they report the leak. So in Philips Respironics, we want the full face mask to have a leak between 20 to 40. If you have someone with a leak of 15 or 10, that might mean the mask is too tight for them. And probably they will be forthcoming and they will tell you that the mask is too tight. And if the leak is more than 40, definitely is on the high side. And there is a difference between leak of 50 and leak of 90, right? So anything more than 40 is considered to be abnormal. Less than 20, that means the mask is too tight, okay? And if they are using a nasal mask and you're, getting a report about, a download report from a Respironics, Philips Respironics machine, then the nasal mask, it should have a flow or a leak of less than 25 liters per minute. So just memorize 25 for nasal, for full face at 20 to 40. ResMed though, it is tricky, okay? Because I told you, they're not gonna tell you about the total leak. So if the mask is properly fit, your leak should be 0. Why? Because the machine doesn't tell you about the total. Why we allow that to be 20 to 40? Because Philips Respironics is gonna tell you about the total leak, the intentional plus the unintentional. But the ResMed, it just cuts it, directly. It just tells you about the unintentional leak. So the way that you interpret the leak is different if you're using ResMed as opposed to Philips Respironics. So can you tell me here what's wrong with this patient? So this is the data for VAPS download data for day 1, 2, 3, 4, 5. Any takers? Hamza, what's the best next step?
So go over it, Hamza, with us, like what are you seeing?
Yeah.
And then what's your next step?
Okay, I see the,
Start from the first column, AHI.
yeah, AHI by increase by day.
And by the way, go to the average, don't go with the minimum maximum.
Yeah, the
Yes.
average is, in day 1 it was okay, then it increased.
Okay,
So
it's
that
getting
means
worse.
Getting worse, patient
Okay.
is getting worse, so.
Okay.
So we're gonna go to EVAP pressure. EVAP pressure average 6, 7, 8, 9, 10. But the minimum is still between minimum and maximum.
Yeah, but you see that the machine is responding by increasing the pressure,
Yeah,
right?
The leak is
Okay.
increasing, the pressure is increasing.
And minute ventilation itself.
Yes.
Let them finish, guys. He's the one who.
Dr. Michael gave you the answer though, anyway. All right.
So at 10 at EVAP pressure. So yeah, so the machine try increasing there's something wrong. The machine tries to correct by increasing the pressure.
Okay. And then now the question is, we will know eventually, was the machine, able to fix it or not? So as you go down, okay. What else happened here?
Exhale tidal volume. So it
You
decreases.
dropped the rate, breathing rate.
What? Oh, so the breathe
Yeah.
rate, yes.
Yeah.
So it's increasing too. So it looks like the machine trying to increase the minute ventilation.
It's trying to preserve the minute ventilation at all costs, right?
Mhm.
Okay.
So exhale tidal volume has been decreasing.
Okay. So that means
There's
the machine hasn't been able to fix it, right?
Yes.
Despite all the
Mhm.
pressure support that it's giving, despite, increasing the backup rate in order to maintain, the minute
leak
ventilation,
has been increasing. So
right? Okay, then the treatment for this would be not to go and increase the pressure. You can increase
Yeah.
pressure
So
until cows
machine
come on,
has
it's not
been
gonna
doing
fix
the
it.
job, but because of the leak.
Is
if
mask
it fits the
fitting,
leak.
right? So
Yeah.
to treat this is a
Mhm.
mask fitting, perfect. Because this is why it's a dynamic process. Prescription, and then you see them in the clinic and decide, is it working for them or not? And you might see the scenario.
What do we mean with unintentional and intentional leak?
So you have a mask, right? So because it's a one tubing connected to the machine.
Right.
Because if there is no leak from the system, then you will be,
Breathing CO2.
breathing your CO2.
Right.
So there is an intentional leak tilt.
So how we know like how much should be for every patient?
This is what let me explain this to you. The intentional leak, there is a mask normally should escape your mask.
Okay.
And the unintentional leak is the one that we need to keep at minimum, which is the thing that, kind of seeps around because of
Anatomically,
dirt, because of, abnormal facial anatomy, the mask being too large, too small. So the Philips Respironics machine is going to report the total leak, okay? So since it's reporting total leak, then there should be some numbers because, there is intentional plus unintentional. We need that to be between 20 and 40 for full face and less than 25 for nasal mask. But when it comes to ResMed doesn't tell you about that. It only reports the unintentional because it takes it away from the equation, okay? So the number, it should be something close to 0 if the mask is okay. Do you see what I'm saying? I can't tell you a number, but it depends on the mask itself, okay? So if it's fitted or not. Did that answer your question?
Yeah,
No.
my question is like, how do I know what is the acceptable leak for every patient and intentional leak? Like it's
You don't have to know. So Yes. So know what kind of device that you're dealing with, ResMed, Philips Respironics, and what kind of mask that this patient is wearing. Is it full face mask or nasal mask? Because that can determine when to say that the leak is on the high side or within normal limits. Did that answer your question? Because it's not like, okay, full face or nasal. No, it's more and it's more complicated, guys. I'm just telling you the easiest way to approach this, because there is tables and they can, go by.
There's Middle Eastern food in a WAD's office, the shawarma, hummus.
Thank you. Thank you. Okay, did that answer your question?
Yes, yes.
All right, so hopefully we have few more minutes. Okay. So what we need to do when we see these patients, please, guys, if you have someone coming to the clinic because of COPD and you say that they are on Trilogy, you have to ask the nurse to get us the report. It's not like I'll tell you. It's not like one prescription that was given to them and then we'll forget about it. So when you see the patient, if they are on Trilogy, it doesn't have to be that you get the report when they have sleep apnea. If they are on the machine, when they come to see you as part of their COPD, because you prescribe this for COPD, right? Or for OHS or for whatever, right? So you are supposed to be getting the download. So you tell your nurse, this machine is using home Trilogy. Please get us the download data and I'll show you how it looks and what to see in the report. Okay. So, but before we get into this, because I have it like a step number 5, number 1, when you see them, you have to ask them about the symptoms that are related to chronic respiratory failure. So like when they have, elevated CO2, they have morning headache, they have nocturnal, smothering, nocturnal, some shortness of breath at night, excessive daytime sleepiness, fragmented sleep. So you ask them about these symptoms because these symptoms, they are non-specific, I'll admit, but patients, when they have chronic hypercapnia, they have these symptoms as well. So if they're getting better with the treatment, and then you have to ask them each time these questions, because if they tell you I felt better for a while and now I feel like I'm waking up smothering at night, stuff like that, that tells you maybe the mask is leaking, or maybe there's some problem, or maybe they put on some weight, maybe the pressure settings that you have it initially set at 5 years ago, it may not be working now. So you start with your history. Second thing, we don't do it, unfortunately, here, which is transcutaneous CO2 monitoring. If we want to make sure that these settings, they work at night and they don't get hypercapnic at night. And then you check their daytime ABG. So when you see them, so preferably there's no clear, guidance on when to do this. 1 week after you start, 3 months. So, but people, they do them when they see them in the clinic, at least 1 month. Okay. So my mentors, she said she used to do it at 1 and 3. Okay.
1 and 3 months.
1 and 3 months at least, the ABG. Okay. You have to know that for COPD, the reason that I'm putting that for you in green, because there is a prospective trial that found this. For COPD, your CO2 appropriate response to home and IV is defined by improvement in your daytime gas exchange, which is your PaCO2 less than 48, or PaCO2 drops by 20% or more from baseline. If you're not achieving that goal, you're not going to have a mortality benefit based on that prospective trial.
You do it 1 and 3 months
At least after you
after you stop.
yeah.
No need to do it like.
No. Because this is different. I'm not talking about acute situation, guys.
Yeah, I mean.
So home. When you see them in your clinic, so preferably you see them in preferably you see them in a month after they get started. But if you can't, at least you shouldn't let that go by more than 3 months. And when you see them, you get provided that they're wearing the machine regularly, and then you check their blood gas, because you have to remember that it may take some time for the CO2 to get down to lower levels. And in some of the trials that I told you earlier, 25% of the people that they screened, and they thought at first that they are candidate, in about 4 weeks they have CO2 that's almost normal. Okay, so you have to give it some time. At least this is why they do it at 1 and 3 months. And again, it's just the expert opinion. There is no strong data to support it. Also, overnight pulse oximetry. Even if they're not using oxygen at night, you have to make sure that the machine is doing a good job. Okay, because if you still have nocturnal desaturation despite having a appropriate response in your CO2, is to maybe prescribe them oxygen at night, or maybe that the machine settings that you have the patient on is failing to ventilate. This is why you're, having nocturnal desaturation. And the most important thing is to review their compliance data. And I'll conclude with this case. So I saw this patient, I think a couple of weeks ago, 70-year-old female, lifelong non-smoker with history of chronic hypercapnic respiratory failure due to thoracic vertebrae deformity, ESRD on dialysis and hypertension. She came to see me in the clinic after being started on AVAPS AE 3 months ago. She was started, I think, in early July, and I just got to see her, just now. The patient was hospitalized in early July for acute and chronic hypercapnic respiratory failure for the first time. ABG prior to discharge showed PaCO2 of 54, and we felt that we have to start the AVAPS, and we started it. So next step will be is to show you why or the degree of the chest, vertebral column deformity and the kyphosis kind of picture. So I think in mid thoracic, maybe T7 or T8 kind of deformity. So this patient, and by the way, this patient was labeled to be COPD if you don't know. COPD. Yep. Full NIPS, steroid.
Have never smoked.
Yep. And she's getting COPD treatment. She's getting COPD treatment and called to be COPD.
You got the lid.
Okay, so the patient, when I saw her, she's very adherent to her Trilogy machine. She's using full face mask, denied having any dry mouth. By the way, when you ask the patients if they have constant dry mouth every night, this is a sign that they have a leak. Okay, so you have to look carefully for that. Patient denied any history of snoring or waking up gasping at night. Denied any morning headache, reported some improvement in her daytime energy. Even she said dyspnea now, she is able to walk even with less shortness of breath during the day. And also her excessive daytime sleepiness has improved. The patient doesn't use any oxygen during the day or during the night as of now. So this is what you get in your, compliance data. So the first thing that I looked at is the settings that her machine is programmed at. Okay, so look at, this is what I asked Rami to do, and I think he put the, clearly the recommendation to them, and they're not, being, applied to the patient. So most of the stuff that we requested, they did not do them. I don't know, maybe they didn't look at this and they used like just generic settings. So this is why you have to look at the settings before you look at how the patient is doing. You have to know, okay, how is the machine is programmed? Because us writing the prescription, that doesn't mean that it was executed. So you have to look at what settings the machine is set at. Okay.
Sometimes you see it is if you do the setting or if not, then we're gonna go with the standard setting that they have.
But if they know this is my
You know
preference.
the settings, and
Yeah.
you preferred some settings, then
then
you
you
should
should-
go with the
with the settings, because when you have put patient on the vent and the ICU, you determine what you put them on, right?
Yes.
And even you tell the respiratory therapist, they might, if they have disagreement, they will discuss it with you, but they will just go with whatever you want them to be on. The same thing also is true here, but actually it wasn't executed, the prescription. So this is the first thing that I noticed, because I have that, saved in my note, the prescription that I just showed you. So the second thing that you look at is how they are using it. And as you see, the more than 4 hours per night is 92%. So this patient is very adherent to her treatment. So it's not her fault if everything is not, working well. And this beige, it gives you like, what is the average. So if you see like the IBAB is averaging around 23, 24 the entire time, and the EBAB is around 10, right? And if you see here, look at how they or what they put in the prescription. The pressure support minimum is 10 and the pressure support maximum is 14, correct? And the EBAB, so I think it's okay, but I should start from 5, because if 6 or 5 opens your airway, I don't need 10, right? Why would I start with 10 unless I know that it's 10?
So ECAP minimum is 10.
Yeah, correct. It should be 5 to 15, and the machine will decide. But anyway, they use
Well, that's what you ordered for, is that right? ECAP
Correct.
5, yeah.
Correct. And if you see here, in this diagram, so since like the sleep apnea or whatever, the upper airway was maintained open at EBAB of 10, so that means the machine.
They have, but
Correct,
maybe it's lower
and the
than
pressure
that.
support.
She may need
No, I think it's the machine. The reason that it picked at 10 and kept it around 10. This is what it takes to keep the upper airway open.
Okay.
But the problem is because you made the pressure support maximum to be 14, right, on this prescription. So this is
can go.
why the IBAB didn't go beyond 24. And I will tell you, this is, you know, insufficient response. So
Can you say that again? Sorry, Tariq.
So I think I'm jumping ahead of myself. When I
That's
do
okay.
the other slide, you will know that. So the EBAB or CBAB, or whatever you're going to call it. So this patient was
So
sitting
now in
10,
this settings, 10 and 14, is that right?
10, 14. Ideally, it should
That's
be
for
5 to 15.
that's for the EPAP.
Correct. It should be 5 to 15, but
That's
the
right.
machine, since that it is, all what it takes to keep the airway open is 10,
Okay.
right? And if you see here, so the IBAB is hovering around 23, 24,
Never
or
above
something like
25.
that, right? And never above that. Just keep that in mind. For me, when I saw this, it's like, well, because the pressure support is dialed maximum at 14. So that means the patient was reaching the pressure support every time. You see what I'm saying?
Yeah.
Because it could have gone more than this, but
Because
they-
you're reaching the maximum.
yeah, you cannot.
Even
because
when you set up the IPAP 25.
I'll tell you something, forbid IBAB,
Okay.
okay? When it comes to setting, because it gets it confusing. It's not IBAB, it is.
Maximum pressure.
support.
I'm talking about
The
maximum.
pressure support maximum is 14.
Yeah.
So 14 plus 10, 24. So that means the IBAB, this is why the IBAB didn't go beyond 24. It is just when you're looking at this page alone. And the next page is going to tell you what is the problem here. So this is a problem, by the way. When you look at it, it may not be a problem, but when you.
prescription one
Yeah, the second. Yeah.
Sure.
I thought the max pressure, which is in respiratory.
No, the
pressure,
maximum, let me go
25,
to
right?
the maximum pressure is 25.
Yeah.
It could be the other limiting factor though,
Yeah.
okay?
this
But
one-
if you see,
Yeah, but
the
another limit-
pressure support
pressure
maximum is
support.
14.
What will limit you before you reach?
No, this is what I wanted. This is what I wanted, but they didn't. I want the maximum pressure support, not 14, 25.
You see,
Okay.
you can do like 10
25 to be 30.
Correct,
Support
correct.
max 14.
I want to give the machine more flexibility,
Right.
not to use a narrow pressure.
25.
Right,
So and if you went with this, so 10 plus 25, you
Maybe
can reach
35.
35.
35.
But because in here,
The pressure support maximum, it's mistaken typing, 35 we wanted them.
Oh.
What I wanted them, I said for this patient, I don't have like any emphysema or anything. I
Yeah,
think
that's
even if
right.
it reached 35, because it needs a lot. By the way, I've heard like listened to like entire lecture by one of the world expert for the COPD stuff. He's from Germany, and he said like your mask will blow out before you have a pneumothorax. He said, I've been doing this for 20 plus years. Okay, so you start with a pressure, let's say in the machine like 35, okay, in the machine, but the patient doesn't see it. Part of it will escape, part of it will go in the tubing, part of it in the upper airway. So the alveoli, they don't see this, okay? So, and the reason for this patient, because bad deformity, and I think it will require more pressure to expand. But if I'm dealing with someone with a lot of emphysema, I may even make the maximum pressure like 25 or maybe not more than 30. But in her case, this is me having a error in typing. I wanted the maximum pressure 35 and the maximum pressure. So this is a safety mechanism in the machine. It will not let your pressure support and IBAB go beyond this.
What's the difference there between the maximum pressure and pressure support max?
So the maximum pressure is the safety, is you telling the machine. So machine, don't let the pressure, the IBAB go beyond that number, even if the machine will determine that IBAB to be needed, because I'm concerned about the patient's safety. And the other pressure support maximum and pressure support minimum, it is the range during or between which the machine will decide which is the pressure support that, the patient will require to generate that tidal volume.
Because IPAP plus
like because
EPAP.
to form a tidal volume, you need the pressure support, is that
Yes.
right? If it's pressure regulated machine. So if the pressure support is 14, which is that's the high, like the highest for this patient will be 10 plus 14, so 24. But let's say that you made your maximum pressure is 20. So it will not reach 24, even if your pressure support is saying 14. But if like we go with Tarek have done, then this patient should be like getting more support because his pressure support max over there.
Correct, is around 24 because so the point here when you see this, so this is a sign that told me this patient is reaching the maximum of her pressure support every time. So without showing you the next slide, okay, so just by looking at this, so this is a sign for me telling me, oh wow, so patient is reaching the maximum pressure support each time. Then the question is, I hope that it is doing the job what it is, you know, supposed to be doing. And when you see here, the first thing that I want you to look at is the tidal volume, right? So I want you to keep pressing in this and I'll explain. If you can go. Oh, what did I do?
No, this one.
Okay. So this is the tidal volume, right? Because this is the main target for which we're tailoring everything. So we wanted this patient to get, I think, 450, 440, something like that.
The prescription 440.
If you see, so this is, I think, the average, my understanding, per week. If you see, like, every week, it just gives you the average. So here it was fine. And then if you see, it's starting to drop, or maybe not bad, not like the case that I showed you, but at least it's not where it needs to be.
Mm-hmm.
So reaching your maximum pressure and you are not achieving the goal. Why? In this situation, one of the reasons is that wrong prescription. Or maybe, I shouldn't say wrong, but anyway, the prescription needs to be changed.
So you're telling us if everything is correct, you don't.
Think that you need to.
I mean, in general, not in this patient. In general, if everything is correct, you don't expect every patient to reach the maximum all the time, right?
Correct. Yeah. So if they reach it all the time,
the volume.
If they reach it all the time, they mean okay.
Or maybe at least leave the patient with a little bit for some room more if needed. Okay?
I see.
So because imagine if the mask is working and then for some reason it's worn out and they don't get replacement, it will start leaking. Then the machine, how is it going to compensate? By increasing the pressure?
And there is no pressure.
There's no room for the pressure support to go beyond.
Like the neuromuscular disease patients, these patients usually go down by time, their respiratory muscle become more weak.
I'll explain that to you. So after I look at the tidal volume, next thing I look at the leak before I generate anything. I told you in the history, full face mask, right? Look here, average
more than 40.
50,
or above 40.
60, 50. So there's something wrong, right, with the mask. So there's at least some leak. I'm not saying that this is the reason, but maybe if this one is fine, maybe the patient should not have reached the pressure support maximum all the time, but it's reaching it because I think it's inappropriate.
Some of the volume is out.
Yeah, right. Next. So next is to look at the iPad. Okay, so if you see here, so it's what I told you.
So it was in the 24.
iPad. Next one.
Patients.
No, hit. Oh, here. This is very important. Okay, it was kind of confusing for me here. I messaged, my mentor, and I'll tell you what she thinks about. My understanding about this was in percentage. So what you have here in percentage, average patient triggered breaths, which is the average. This is the percentage. Okay, so their respiratory rate at night,
like 18% average.
So
for the whole week,
every particular night. So the patient triggered.
So that's not the rates of. That's not that.
No, not the rate. So let's say that they generated per minute the average 16 breath per minute for that week, for example. 18% of them are patient triggered, and the rest is machine triggered. So that means their respiratory rate drops below what's considered to be below the rate that you opted to have them on, and the machine is kicking in. So that means the patient is getting more support, okay, which is more the backup rate is kicking in about 80% of the time for this week and almost 90%. So this is good and bad. So let's go to when we consider it to be bad and when we consider it to be good. So we consider it to be, and always, she didn't give me any specific number and there is no agreement, okay, but we need to keep it on the low side. And the reason is, And this is what I told her in my explanation. She's in full agreement, but she doesn't know exactly any number. Just keep it on the low side. One of the theories about the COPD that I explained to you. Okay, people, they work hard during the day, they have hypercapnia. So if you want them to work hard at night, then just leave them alone. Don't put them on the machine. I'm not talking about someone with a sleep apnea.
Yeah,
So we need to put them because we need to rest the respiratory muscles. One of the theories is to
Makes
rest them
sense.
so they become more efficient with gas exchange during the day. If they are triggering like 90% of their breaths, then you're not helping them that much. Okay. So we need to keep it on the low side. Okay. But in neuromuscular disease,
you need to keep the patient trigger on the lower side.
correct.
That's the
Okay.
COPD patient.
Correct. And how
You're
does
resting the
it-
diaphragm.
you brought up this? What if it is? Let's say that this patient,
Neuromuscular.
you said that in this prescription, the tidal or the respiratory rate backup rate is 12. Okay. And this number across the board is about 50%. And you want to machine to help them more. What settings that you need to change?
Increase the.
Increase
The rate, but you have to do it carefully. It's not like make them 30 or something, then they will have
This
you know,
number help you.
dynamic hyperinflation and stuff, especially like with COPD, we have to be careful, especially if they have, cardiac comorbidities. So, where were I? But in neuromuscular disease, if the patient themselves, without you using, a higher rate and stuff, even like, acceptable backup rate, and this number is on the low side, and you see it each time it's getting, declining, this is a sign that their disease is getting worse. This is to answer your question. Next.
I did down.
There's nothing.
Down.
Okay, so this is the one that I told you earlier. I told you hold on this TI/T total. So this is I to E ratio, right? So if you're dealing with someone with COPD, what is the percentage that I told you? 25%,
Yeah.
which is almost I to E to 1 to 3.
Mhm.
Why? Because if you
1
have
to
1
2, 1 to
divided by
3.
4, that's 25. So that means if the cycle is 4 seconds, one of them is inspiratory, 3 will be expiratory. So, and for the neuromuscular weakness and the other, so we need that to be around 25, correct? So if I come here, where the,
Yes. Yeah, the last
The
one.
last one.
yeah, so it's around, like 40, let's say 40, if you look at this. So I think we need to give them more time in what?
To excess.
No, we give them more time in respiration because this is.
Oh, that's, yeah.
This is maybe what I would say for COPD, right? But this patient has, thoracic, cage abnormality. So in this situation, we have to adjust their TI time, okay? So
You will
that-
increase the TI.
correct, increase the TI time, whatever you use like for this setting, because there is no way, this is
And that will
value.
increase that percentage, is that right?
correct, supposedly.
Yeah.
Because if they're relying on the machine,
Yeah.
a machine triggered breaths.
Yeah, because 90% of the triggers in here is the machine triggered
Correct,
breath,
correct.
so it should be
And
combined.
this is variable. There is nothing on the machine that you can dial and please make the I to
Yeah,
E
you
ratio.
cannot, yeah.
You cannot. And at the rate, this is what you decide, but the machine, remember, the patient can breathe more than what you said, but at least the variable that you need to change is your I time. What is next? I think next is this one. So apnea count or HI, if you see, it's all 0. So that means the minute or the target volume is not being reached, not because of upper airway obstruction. The machine is fixing the sleep apnea. part.
apnea time is 0,
It doesn't have to be sleep apnea, by the way.
Yeah.
Even when we get older, there's some degree of, whatever.
it's 0, so.
Correct. So it's not upper airway issue that's rendering your ventilation inefficient. It is your lung mechanics and your settings. Okay. Any questions?
Oh, thank you.
When you look at this, so this is you follow
very
up with
good.
this.
Can we get the lectures, like all of them to be sent to us?
All right. I think this is yeah.
So all of this is.
I think it's recorded
Recorded
even.
On YouTube.
Your last lecture is not there.
Yeah, it's not, sometimes it takes time even to be uploaded.
It takes time to be uploaded, but it will be
Yeah.
How
there.
can we
You can
stop
upload
this?
it.
Yeah, but these slides are very important for.
Yeah.
Wow, this is very
And
good.
3 of them you can get,
Okay, guys, you keep take
Excellent.
especially like the others. I think you can remember, but this one, when you write in your note, pull up this and go step by step.
Thank you.
Shukran,
Okay, no problem.
Wallah, mashallah. It was good. We
problem.
understand. too many now. So we have to go for sleep medicine, man.
No, I mean this is not sleep, by the way. No, this is pulmonary. Each pulmonologist, we should know this.
Yeah, but the